Hey guys, Dr. John here at the Voyage Clinics podcast. We're here with our super nerds in the clinic, Eric and Derek. We call them the Ricks, and we're going to be talking about placebo, snake oil, belief in medicine. We're going to talk about a lot of really cool things, and so I'm excited about today's podcast. All right, welcome Eric and Derek. Thank you for joining me on our podcast today. Excited to have you here. Tell us a little bit about you guys. I call you guys the nerds of our office. You're both really nerdy. They've been working with me for about a year now, right?
Yeah,
like close to a year. Both pre-meds. Derek's on his way to Texas A&M.
Texas Tech.
Texas Tech. I always get those mixed up. In Lubbock, Texas. Yep. That'll be really exciting. Specializing in family medicine like me. That's really fun. Excited for your journey. And Eric is pre-med and looking to apply for med school this coming season. And so that'll be really fun. Tell us a little bit about you guys. Derek, start with you.
So I'm Derek, one of the medical assistants at Voyage, also a sleep coach and a health coach. Kind of like to connect with the patients in any way possible to help with their care. I'm a graduate from BYU in neuroscience. Did some research there on different neuroscience things, mostly how different addictive drugs affect your brain.
Cool.
And that's what I did there. And now I'm going to try to do family medicine at Texas Tech.
Yeah. We're excited to hear a little bit about some of that brain research. I know it was done on rats, but still pretty interesting stuff. Eric, go ahead.
Yeah, I'm Eric. I also graduated from BYU with my major of neuroscience. While I was there, I did 1.5 years of research on sleep and suicidality and kind of how those two interplay. I'm also one of the sleep coaches and health coaches at Voyage, and it's really been awesome.
You guys have been really cool. These guys helped us develop a sleep coach program, which has been really, really cool. Just sleep is fundamental, foundational to our overall health and wellness, from weight loss to mood to all these things. And so really grateful for your guys' efforts there. Let's dig in just a little bit to this today. So we're going to talk a little bit about, belief and science and what is science. So I guess we can kind of talk about like the fundamentals of science. Eric, you guys are just coming off of science degrees, right? You're both neuroscience majors, which clarify the difference between neuroscience and what is the other one?
Psychology.
Tell us the difference. Yeah.
So I would say neuroscience takes a bottom-up approach where psychology takes a bottom-down. So we start with how a neuron works, and then we build upon that to figure out how eventually behavior works or how individual neurons interact with each other.
Oh, cool.
I guess just kind of adding on to that, one other thing I like to think about when I'm describing it to people is if you have like a machine and you imagine you got like these inputs and you got these outputs to the machine. Psychology is a lot of studying, we get this input, what is this output if the machine's the brain? And the neuroscience is trying to figure out, what goes on in that brain between that input and output. What is that processing? What are the structures underlying it? And can we understand and put some names to this input and output that we learn in psychology?
That's really cool. Well, thanks for that, guys. I think, BYU is a cool school, and I went to the opposite of BYU. UNLV, I'm like the rebels, the running rebs back when I was in school. So anyway, it's really fun to be with you guys today, even though we're totally different culturally. It's fine. Let's talk a little bit about science and your guys' journey in science and how, in medicine as family docs and as all docs, right, really, we're really heavily taught science. Like that's the whole thing. And I remember as a young kid, like my family's big into hunting and fishing and stuff. And I remember skinning this giant elk one time and just looking at all the organs and like have my hands deep in these steamy, awesome organs. And I'm thinking, this is rad. Like, how does all this stuff work? And just piqued my interest in science and the way things work. And I think there's all kinds of different aspects to science that are super interesting. What are your guys' thoughts on science and how, what piqued your interest in it? And in medicine, maybe we can go there too.
I think I just really love to know how things work. And I think that's just the mission of science overall, is to understand the world around us. What exactly, is everything and how does it work? How can we take advantage of that knowledge to make the world a better place around us? And that's kind of what interests me about science, but especially life in the human body. I think it's especially intricate and complex, and if there's a lot of space in that area to help us humans, understanding ourselves. And so I think that's a lot of what science is about to me.
That's so cool.
Yeah. Similarly, I love figuring out how things work. Just always have. And so I don't really see anything more complicated than the human body.
Yeah.
Based on, what I've done, maybe astrophysics, but
Rocket science.
Close
yeah,
second.
rocket science. And it's just so interesting. And even just like this last year of working with you, I've seen so much and I've learned so much, and I just know there's so much more to learn.
Yeah. The longer I'm in medicine as a doc and I'm exploring the depths and breadths of science, the more I realize there's lots of stuff we still don't know, right? What's fascinating is even in like medicine, in science, there are ends to what we know, and then we push those in the form of research, right? We try to there's lots of ways that we push the limits of understanding of humanity, and we will push it in observational studies. We push it in all these different types of techniques, and I realize our own limits, and it's okay. Unfortunately, where science is at the end of science creates this gray zone of like, woo. And so then you have all these like other folks that say things about the end of science, and they have opinions and thoughts and ideas, and some of them may be true, some of them may not be. They're just hypotheses. And so I think the process of discovery of science is lovely. We're just learning about the way things work, whether it's the body, the world around us, the brain. I think it's super rad. And so I want to talk briefly about the way that we in science, the way science expands in the United States. So, or probably in the world, is very similar. So we have these like educational institutions, right? And med schools, universities, and then there's private sectors as well. But they all do research, right? And so what are like the basics of the studies? Part of our goal today is really to discuss science, the importance of science, and then how do we navigate truth versus pseudo-truth, and in like taking care of our bodies. So there's lots of people selling stuff, snake oils and weird wackadoo things, and some of them are okay, some of them work, some of them don't. Why do those things work? Why do they not work? We're going to explore that space. But I want to talk briefly about science and how we push the limits of science in our university settings, med school settings, private sector. What are the research types, and what are the strengths of each research type? So you guys are really savvy with this. Eric, go ahead.
So one of the research types is observational studies. So this is primarily what my lab did. So we took people with suicidal ideation, we took people without, and then we put them through a couple things. So we weren't trying to prove causation. We weren't trying to prove anything. We were just looking at, okay, is there a connection there?
Yeah.
And so observational studies are great because you can say, hey, there's something there. We need to look at this more. But on the downside, you can't prove anything as far as causation goes. So in my lab, we can't say, oh, hey, your sleep is bad, therefore you're going to have suicidal thoughts.
Yeah.
What we can say is there's a connection there.
Yeah. I love that. Correlation, causation. I love that you refrain from using technical words, but it is. Correlation does not necessarily mean causation. So there's a connection. We're not sure if it was causative yet.
Yeah.
And so that's really cool. Retrospective studies. Derek, do you know much about these?
Yeah, so there's retrospective studies where you have you look back in previous years of a bunch of data that's been collected, and you try to, draw some conclusions, see some correlations, and be like, oh, looking back on this data that's been collected in the past, these things that have happened in the past, what can we find that's like connected here, and what can we learn based off of these big data sets? And like we were saying before, you can find correlations, but you can't find causations when you're looking back retroactively.
Sometimes people lean into some of these studies and say cause. They'll say cause. And I love that both of you guys said connection. There's a connection, correlation, but we can't definitively say cause, right? Yeah. And so we often see folks misconstrue studies all the time that are not designed to be proof of cause, and they pull them into that sector. And it's easy for us to get confused on that space too. Other types of studies that are decent, meta-analyses. Can you break this one down?
So a meta-analysis, oftentimes when you have, individual studies, there's limits of funding, limits of time, limits of researchers and stuff like that. And so they have like, a limited sample size and can only do so good of a study. And so what meta-analyses seek to do is to gather as many studies as they can, looking at two variables, kind of they have their conditions, like certain standard of study has to be like certain types. They kind of eliminate the ones that they can see lots of bias in, try to get the best quality studies that they can, and then combine all of the data into one big data pool to make a conclusion based off of it. And so what this does is it increases the sample size and makes it easier to get statistical significance in a study. It makes it easier to report findings that maybe weren't seen in individual studies, but once you get enough power in the study, which is achieved through a bigger sample size, then you can find some results.
Gosh, this is why you guys are my nerds. I love that. That's a good breakdown. That's a really great breakdown of a meta-analysis. Again, is it designed to prove causation or just more correlation, more connections to these kinds of things?
And it's really, not supposed to be causation, because usually what makes up a meta-analysis is a variety of different types of studies, and usually most of them aren't the types of studies. Some of them might be ones that could, imply causation, others are more observational, and when you're mixing and matching study types, if that's the case in the meta-analysis, then you really can only draw correlations and, future study type of ideas.
But good scientific cool work, and those steps are all very, very important and very, very cool. Let's talk about clinical studies, research, where we get to the rub of cause. Eric, break some of those down for us.
Yeah, so clinical research is going to actually apply something. So before we've been talking about, hey, we're looking at two things, let's see how they're connected. In a clinical study, they're giving you the medication. And so they are actively causing something to you to see the results.
Yeah.
And so there's also a few different types. And the first one is your doctor knows what they're giving you. So they're either giving you the medication or they're giving you something else.
Yeah.
So they know what's going on. And because of that, there can be a couple confounding variables. So the doctor might treat a patient who's receiving the medication differently than a patient who isn't.
Sure.
And so this can cause a couple of issues.
So it's not double blind. The most, like, the standard of, like, the best evidence of evidence is double blind randomized controlled trials. So double blind. So both the doctor and the patient are blinded. They don't know if they're giving the right thing or the wrong thing. And there are some variants to that, like you said, like some of the ones that the doc knows, but the patient doesn't know. And that's where causation comes in. And that's really fascinating. I think that's really try to kind of where we build, like, in all through med school, all through residency, all of my gray-haired attendings, I'm now the gray-haired guy. They're all talk about, evidence-based medicine, evidence-based practice. And so we try to look at the science, look at the data, make sure that there are reasonable studies that can contribute to our practice of treating and helping and advising people. So I think that's just really, really clutch. I think as healthcare providers, our goal is like the Hippocratic Oath, right? Is like part of some of our standards, and it's do no harm. And I think that applies both physically, emotionally, socially. You could do massive social harm if you just indoctrinate people incorrectly. You tell them a bunch of falsities, and as a healthcare professional, you're given a sacred role to be their advisor through life, through health, and all that. And so I think the Hippocratic Oath is more than just like cutting someone that didn't need to have surgery,
Yeah.
It's more than that. And it's financial as well. I think some of those problems can be financial as well. Let's move to some of the things that make a good study. If you're in the research space, if you're looking at a study and you're trying to figure out, is the strength of the study good? Is it bad? What are some of those variables that we kind of look for in, like, just looking at a study?
I think just one of the first things to understand is that science is hard, and that making an experiment is hard, and that there's lots of different factors because you're trying to isolate an effect. You're trying to change only one thing between two groups to see what effect that one thing has.
Yeah.
And so what you want to look for as you read through the methods, if you're doing that, is, are there any chances that there was more than one thing different between the two different groups? Is there more than one effect happening? And that's kind of the overarching thing to see if there's bias in this experiment. And so examples of that, we talked about being double blind. If the researcher knows that they're giving you a medication versus a placebo, they might treat you differently than if they knew they were giving you a placebo. And that's an additional difference between the two groups. So being double blind, the person giving the drug and the person receiving it don't know if it's a drug or a placebo. And so that eliminates that opportunity for bias. And then the placebo control is another thing itself. If you do nothing at all versus giving them something, that is a difference. And so instead of just giving them nothing versus giving a medication, you're going to give them something, but it's not the medication. It's a placebo, something that's meant to do nothing. However, there is such thing as a placebo effect. Giving them something that doesn't actually act on their system the way the medication does can still affect their beliefs about what's going to happen. And so that's one thing that could be different between the two groups, is if they have different beliefs about what they're getting. And so that's why you have the placebo control, to try to keep those beliefs the same as much as possible.
That's the placebo control is whatever you're giving them that's not a medicine.
That's not a medicine.
And is placebo effective, and to what percentage? I bet it varies a little bit to degree by what study is what. I've heard it can be up to as 30% effective, which is amazing. That's amazing. Like you can give somebody a sugar pill that works 30% of the time. That's phenomenal. I want to circle back on that. I'm gonna put a pin in it, but we will circle back on placebo and belief and the importance of that in our healthcare system. I think we are so heavy on science, like, double blind, randomized controlled trials, which is important as well. I think that's super, super clutch. But I think that we discount placebo, and we sometimes do things that create a nocebo effect, which is like the opposite of that, creating doubt and distrust in something that we're giving somebody, and thus creating the opposite of that a pretty large percentage of the time. So we're going to talk about that in a little bit too. Strength of studies, I think we've gone really kind of nerdy into the science realm of things. And I think the average one of our clients really doesn't pull up PubMed and read an article and strength of study, what's the end value? Like they're not looking at that stuff. So let's just move through like maybe some resources that folks might use to navigate science. Like where do we go to find good information? There's a lot of places we go to find bad information, right? Like let's talk about the bad information ones real quick. So Eric, what are they?
Instagram.
Yeah, let's go. Let's just, everybody's an expert just saying stuff, and and there are some experts on Instagram, but there's a whole lot of people just spouting opinions. And so Instagram, TikTok, the social media platforms, for sure I've seen wackadoo stuff. I've seen very sophisticated wackadoo stuff, and there are very sophisticated websites. During the COVID thing, holy cow, there was some sophisticated wackadoo. We call this is a term we use in our clinic quite a bit, wackadoo. And there's just wackadoos out there, and they're doing wackadoo stuff. But in the COVID thing, there was some real bad things, and they were preying on some people, and some very vulnerable people, and that's a shame. That should be wrong. So let's just speak briefly about some of the sources that we can go to find good evidence information. Derek, you got a couple?
Yeah, I think that just since it's really hard to read and like distill large amounts of studies, especially then the second barrier is even accessing those studies. Most people don't have access to them unless they're part of a major institution that gives them access to them, because they're expensive to get subscriptions to journals.
100%. Luckily, we have I'm adjunct faculty at a couple medical schools, and so we have access to all the databases, but you're right, they're behind paywalls, so they're very difficult, which means that we have to lean into some trusted organizations maybe. What are some of those, Eric? You got some?
Yeah. So like the Mayo Clinic's website is pretty good.
Yep.
The Cleveland Clinic, there's a lot of them out there.
Yeah.
Typically they're organizations, and they have a lot of good research to back it up.
Yeah. Derek, any other ones that you can think of?
One thing that we've recently started utilizing in our clinic, it's a website called Examine, and they summarize studies on supplements specifically.
Yeah.
Especially because the supplement space is a really difficult space to navigate. And so to have someone else who's, does research all day, every day, and summarizes as unbiasedly as possible, to do all that work for you, and you kind of just skim over what they have found from all the different articles they've searched through. And it takes some trust. You have to trust that the individuals doing this are doing it, as unbiasedly as possible. But with that trust, then you can, go through the website and you can find lots of different information on different supplements, possible benefits they have, possible, things that they don't do, and sort of things like that. See what has been studied and what hasn't been studied.
Examine.com. This is a really great tool. We've been utilizing it in the clinic now, and it's really cool. For supplements, for different things. A lot of times folks will say, hey, this works for this. And you can look it up there and see if there's actual studies, backing that up. Does it mean that when someone tells you this works for this, that it's not true?
No.
Tell me about that.
So that's kind of in your anecdotal evidence, and that can be really hard to parse out.
Mm-hmm.
There's a lot of emotions when we talk about that. Like, oh, hey, this worked for me. I was really sick. And that moves people to get those medications or those supplements or whatever it is.
Yeah.
And so I think on our side, we're a little more inclined to be like, well, that's, not real. That's not evidence-based, when really it could be.
100%. There are certainly solutions out there in the nature space. I mean, my mom is a hobby herbalist. We did homeopathy and herbs and poultices all growing up, and it was great. And some of it was really cool, and it worked for me. And so I'm very careful never to burn somebody's hope, right? Somebody's belief in this thing that's going to help them, because I'm burning placebo. I'm burning their belief that thing will help them, and it could help them. And that's awesome. But if it actually helps them science-wise, that's cool too, even cooler. And so I'm really careful. If there are a lack of studies, it doesn't mean that it doesn't work, but we just have to be more conscientious about that decision. There are lots of people, like you said, spreading falsities and making lots of money in the space of the supplement space, right? And that's really tough. I think as physicians, we're trying to give good advice. We're trying to, advise folks to do this and maybe not do that. One of the things we try to avoid in that space is conflicts of interest. So if I have a supplement that I'm selling out of my office, making a bunch of money on, the temptation is to advise everybody to use that thing. And so I think that's one of the red flags that we were kind of talking about, where, they're just red flags to sometimes when folks are advising you to try this thing or try that thing. If there's a conflicts of interest attached to it, that's really tough. We live in the land of anecdotal, testimonial driven supplement stuff where we're it's very prolific here. There's lots of multi-level marketing things. And those are all like, hey, Aunt Judith and me, we both tried this thing and it worked for us. And you should also sell it to all of your friends and make me a bunch of money and you a bunch. And so it's just hard, right? Like, is that real? And I think sometimes maybe it is, but oftentimes maybe it's not. So some things to pump the brakes on when folks are giving you some advice on a thing, is there conflicts of interest attached to that? What are some other things to maybe pump the brakes when somebody's giving you some thoughts on a thing?
Sometimes they use a lot of sciencey terms, and things that you really aren't supposed to understand. And recently we had someone present to us and they were using a lot of words and I didn't know what they were. And did you know?
Depended on the word.
Depended on the word. Okay. Yeah. But it was I have no idea what these things are. Yeah. Even my undergrad education, which I thought was pretty robust,
it's robust,
prepared for it. And I'm I don't have Dr. John's, years of experience and, med school. And so I'm it sounds good, but is it good?
Yeah. Oh, trust me, there are plenty of PhDs out there, lots of folks that know more than me. And I don't claim to be the all-knowing person. It's interesting that you said that though, because I've had that as well. In fact, one person, a member of an MLM was talking to me and selling me a thing. she was saying it works on the epigenetic level. So I'm like, whoa, there's nothing that works on the epigenetic level that we know of, like in science. Epigenetics is this theoretical space of, I have genes, they're 3D printers, they print off proteins that do cool things in my body. Epigenetics is the study of what turns on this gene in this person, but not in that person. And for them to make that claim is just very sophisticated, right? Mm-hmm. Clearly a PhD level, biochemist has been looking at that, and maybe a study in the epigenetics of rats over here, but hasn't been proven in a double-blind placebo randomized controlled trial over here. But he's making that claim in a very sophisticated way, using very sophisticated PhD terms that, frankly, are unethical to use. Like, whoa, not cool. I think we talked a little bit about sources for people to go to, and some sources maybe to stay away from. The National Institute of Health is another good one. NIH, I think, is a .org. A lot of the .gov things are okay. I would say recently some of the .gov crap is crap. I don't know what the COVID happened to us, but something did, and it was whoa. But I like the Mayo Clinic. I like the Cleveland Clinic. As healthcare professionals, we also have really good databases that we look at on a daily basis. You guys have access to some of these in my clinic. As adjunct faculty at some of these medical schools, they give us access to their databases. Some of them are like up to date, and so they kind of keep us up to date. And we're careful to read the most recent treatment guidelines for this thing or that thing, because they change. Over my short time in medicine, I'd say more than a decade, things have changed remarkably. And so it's good to stay abreast of those things. The other ones, Dynamed, Visual DX, there's a whole bunch of really good ones. MedConsult, there's a whole bunch. And they're all really, really cool. And they're just some of the ways that we stay abreast of the research and stay on top of evidence and all that stuff. That's really good. I want to talk a little bit about conflicts of interest. We talked a little bit about that in like maybe the nutraceutical space. I want to talk about it in the healthcare space. Like we're not devoid of this, right? And so are we guilty in healthcare of some conflicts of interest? And have you guys seen any examples of this? Like at an office, maybe like you felt, like, whoa, this guy seems to be selling me some stuff, right? Anything like that you guys have experienced in your healthcare journeys?
I think one thing that comes to mind, I was talking to my grandma the other day, and she was telling me about this clinic that she'd been going to. They were doing this treatment on her arm, and she was saying like all these things about it, and like the way that they'd been like marketing it to her. It was something that I'd recently looked really thoroughly into the research for, because we were looking into the same sort of therapy for our clinic. It was for shockwave therapy. Mm-hmm. And the way that this person had been marketing it to her were a lot of claims that weren't really super evidence-based. And then he was also charging her like over double what we've learned the average price is for these treatments, and even telling her like, oh, the way I do it is better, so don't go to the other places, like I do like the right number of like, time and shocks and all these different things, and you'll get way better results here than anywhere else, and like keep paying the super high premium for these treatments. And I think a lot of it, these devices are expensive. And so to like, I think when clinics invest in some of these devices that might, be evidence-based for certain things, might not be everything they say that they're for, but they are evidence-based for certain indications, then they feel this responsibility to make back the money that they used to purchase this device with. Yeah. And so they're trying to sell this product to anyone who may or may not need it, just to like make back the money they spent on it and make a profit out of this.
Yeah. It's hard to navigate that space as a consumer. And I think as healthcare professionals, it's our responsibility to help our clients do that and maybe avoid some of those conflicts of interest, even if they're for reputable things. Like do the evidence-based thing, but then you have to figure out like, am I doing this because it's the right thing for this person, or am I doing this because it helps my pocketbook? An example, surgery. So as family doctors, we advocate for our patients in all of the healthcare system, and we try to avoid all conflicts of interest. And so when I refer somebody to a surgeon, I don't get any kickback for that. When I prescribe a medicine, I don't get any kickback for that. that's illegal. It's been illegal for more than 30 years. And so, so I'm really careful to advocate for my people. And one of the things I look for as I refer to folks is, were they willing to not do surgery? If I refer to a surgeon and they send them back to me and they said this, they're not ready for surgery, I want them to do X, Y, and Z things first, that instills trust from me to them, and I can further advocate for my clients by sending them there. But I think those things are really, really, really good. So because we can, should we, is the question that we have to kind of constantly ask ourselves as physicians. Like, yeah, I mean, I can advise this person to buy this supplement. Should I do that? Like, therein lies the rub of like moral ethics and all that. And certainly I've seen, like, along my journey, like I've been in this for a long time, I've seen chiropractic clinics that are very unethical. I've seen nurse practitioner or PA run little places that are very unethical. They're very clearly selling a whole bunch of things, and they're spending time with people. They're gaining their trust and their faith, and then financially just taking them. And I struggle with that. I struggle with that, which is part of the reason why we're doing this podcast. So folks can have an understanding of that these things do exist, and then have an understanding of when to pump the brakes. Like, should I pump the brakes in this clinic or in that clinic or in this setting or that setting?
So that can be really hard, like, as a patient, because when I go to a doctor, there's already a level of trust there. And so, like, I've gone to a few different specialists and I completely trusted them. And for me, it was okay. But how can someone like me, a patient, if we're going to a doctor and they're doing these interesting things, how do we know to pump the brakes? Because there's already a level of trust.
I know. Therein lies a real moral dilemma. And I think that is exactly why we as physicians have to take a super hard look at ourselves. Constantly. I'm like always looking at myself. Am I doing the right thing for my people? I've had a lot of different people come to me trying to sell me a thing so then I can make a bunch of money off my patients. And I'm like, no, that's not my why. I don't care if there's more money in it for me. It's not my core value. And as docs, I think we are, if we're truly aligned with our hearts, we're resonating at a frequency of care, and we're really caring for people. And that means we have to continue in that state of, am I doing the right thing? Or did I just sell that to someone because I made a little profit off of it? That's really tough. That's really tough.
Yeah, and I just want to point out, like, I've been in meetings with, Dr. John and the rest of our staff where someone was trying to sell us something to make money. And afterwards we talked about it and we're just like, we can't go that direction, even with simple things. Mm-hmm. And just kind of taking a step back and going back to our core values.
Yeah. One of the things that we do is really poor business practices, which is we charge almost no margins on anything that we do. And it's actually great because it keeps us from conflicts of interest. So we try to be at break even on, if we do like an IV hydration on somebody, or we do a medicine or something, just to avoid the temptation of that kind of practice. It's really important. It's really difficult because your margins are razor blades and you're just like, how do I make this work? But it's really important. And I think the moral high ground is more important than the money. Just is.
I think one thing I just wanted to just bring up on the idea of like red flags and things to look at when you're going places.
Yeah.
I was listening to someone talk once. They worked in like difficult discussions their whole life. They worked for the government, trying to negotiate hostages out of places, and just really difficult negotiations their entire life. And one thing that they said, like one red flag to always look for is like, hey, this is a win-win situation, this is a win-win situation for us both. Like presenting this thing to them, because it always means that they're trying to like get something from you. They're trying to exaggerate how it's a win for you when really they're the ones that are mostly winning out of this. And they're just trying to convince you to see it as this great win-win situation.
Seems like there's been a recent thing in our clinic with the guy who's trying to sell something just like the exact same. She sees the same phrase. This is a win-win, doc. Don't worry. No.
So it's a red flag to look for, I think.
I love that. That's wonderful. I wanted to briefly share a story and highlight another. It's a funky conflict of interest that is in medicine, and it's unfortunate in my opinion. In most all of medicine, it is illegal for doctors to sell things and make profit, like sell drugs and make profit. In hematology, oncology, cancer treatments, it's not illegal. So the hematology, oncology doctors make a cut of their chemotherapeutic agents and their various, agents. And I've always had a big issue with that. Like when I learned about that, I was furious. I'm like, what the hell? I referred a patient when I was a country doc in Moab to an oncologist. She was older, lots of other healthcare issues, and she had a type of cancer, and I referred her to hem-onc to just discuss kind of palliative care and that, because it was a slow growing cancer. It wasn't probably going to kill her. She was going to die from some of her other healthcare issues. And she had a decent quality of life. Wasn't really affecting her negatively at that time. So I sent her to hem-onc, and a couple weeks later I see her and she's really sick, and I had to put her in the hospital, and she's on like a chemotherapeutic agent. So I was mad. And that's me. I've calmed down quite a bit in my career, but I was a little feisty early. So I called the oncologist as an advocate for my patient, and I was like, what the hell just happened? And I had to eat crow because the oncologist actually did a wonderful job. And this mom was not pressured by the oncologist into starting this medicine, but by a family member who was adamant that mom needed treatment, and it was a child. And so I watched her suffer brutally for months and die. And it was sad for me, but I still love them and care for them. But I was wrong. I thought that conflict of interest created a thing, and I was fired. I was ready to yell at this doctor. Doctors are interesting. We talk to each other that way, and we're used to it. Actually, we are used to being like called out on our stuff, and we're like, oh, okay, that was wrong. And it's good. It's actually a great culture of medicine, I think. But in that case, I was going to call her out, and I was wrong. And I was able to just eat crow right on the spot. Okay, doc, thanks for reassuring me. I was just advocating for my patient. And she says, I appreciate your advocacy for your patient. And so, but your fire is fiery, and that's cool. And so, yeah, these guys have seen my fire sometimes. It's cute. It's cute. It's just what it is. I think it's genetic. I don't know. That's not evidence, by the way. That's not true.
Anecdotal.
Anecdotal, for sure. So yeah, I don't know, guys. I think I struggle in that space still. It is a space where I will call out the oncologist. And now in my attempts to advocate for my patients that have cancer, I'll just give them a spiel. I'll call them and say, hey, let's have a doctor-to-doctor before you visit with my patient. And then I'll talk to them and say, hey, this is the situation. Let me give you the background and the backdrop so that you have information that you can then build on. I don't think that hem-onc doctors are sleazeballs. I do not think that. In fact, I would say most doctors have a pretty strong moral compass. In my experience, I've dealt with gazillions of specialists and all over. And you always hear these little hopped up stories of, oh, these OBGYNs, they all do C-sections, blah, blah. The hem-oncs always prescribe these medicines because they make money. And I'll just tell you, like, it is very, very, very small minority of, does it happen? Yes. Abuse happens in medicine. But I'm going to say, compared to your mechanics that tell you need XYZ extra stuff every time you go there, like the doctors are not that. They're truly in it to care for people, trying to follow moral compasses and looking at themselves and all the evidence. And so it's a good journey.
Yeah.
Are there topics that you guys want to discuss? Anything specific? I think we could probably spend a whole podcast on stem cells. On there's a whole bunch of stuff out there. Today, I think our objective was to lay some groundwork for people to navigate the quagmire of truth. Like what is muddy, what is very clear, what is in between, and and where are good sources that we can turn to kind of find good evidence-based things. Any other thoughts or comments in closing, guys?
Do you want to go further into the placebo effect?
I do. So let's cut to placebo right now. Give it a pause. Today in our podcast, we talked a little bit about placebo and nocebo. And I really want to get into this because I think I don't like the word placebo because it has kind of a negative connotation to it, right? And we're guilty of that. It's the scientists who say, oh, it's just placebo. No, dog. No. We need to roll that back. So I'm going to call it placebo, but I'm going to also call it belief. And belief is powerful and it's awesome. And I think we as scientists need to lean into that. Maybe as clinicians need to lean into that. The scientists can keep on correcting it out of their studies. I think that's necessary and good. But as physicians, I think it is really important for us to validate, empower our patients, and instill trust and belief so that they can maximize the effect of placebo, of belief in a thing that I'm prescribing or advising you to do that's not a prescription or is a prescription, that is going to work. What are some of the things that you guys have seen in the Voyage clinics that helps build belief and trust?
So I think with our sleep coaching, we are doing like evidence-based practices. So we're giving them behavioral changes so that they can sleep better. And it's really simple. And because of that, a couple of people have kind of pushed back, being like, it's not that simple. Come on, like, give me something more intense to do. And I think what we just have to do is, in our role, is to let them know, hey, this really does work.
Yeah.
And reassure them. And then, they make these changes and then they start sleeping better.
Mm-hmm.
And is that entirely the behavioral changes? It's mostly, but we're adding on that placebo effect because you're literally changing their brain.
Yeah.
Mm-hmm.
Super cool.
I think that just one thing that we often talk about, or I've heard it talked about as like placebo effects and like a treatment effect for medication is kind of being opposition to each other. Like, oh, it's either like a treatment, like a placebo, or it got this treatment. It's kind of like a one or the other. But in reality, they're two separate effects and they can be synergistic. They can add on top of each other.
Yeah.
And so, for example, SSRIs have gotten, big pushback from different people for being a large amount due to placebo. And it is true that they do have a placebo effect like other drugs. However, they also have plenty of studies showing that they do perform better than a placebo. So the actual effect of blocking serotonin reuptake is beneficial for treating anxiety and depression and these other things. And it's important to note that the additional effect of believing it's going to do that and having that expectation that your symptoms will improve combines with the increases in your symptoms that happen due to the actual mechanism of the drug to make it work even more effectively than either one by itself. And so while it is true that like if you to take an SSRI and believe it's never going to work for you, does it have less of a chance of working for you because of these belief effects? It most likely would. But that doesn't mean that it's not doing anything by itself. There are these two separate effects that combine to have an even more robust effect. And so at Voyage, because we want our patients to have the best outcomes possible, we recommend them things that have research and evidence behind them. They do work. And then we also let them know that they do have that research and evidence. We reassure them that they are effective treatments. They do work so that they believe it themselves. And these two effects can then combine to get better treatment outcomes.
I love it. That is true. We largely do things that are evidence-based. They've got a lot of good science behind them. We're making good recommendations. I would say when I practiced in the South, I trained in the South, both med school and residency, and I love it. And folks come in and they believe you. They just do. You're a doc, I believe you. And it was great. In Utah, I don't know what this is, but there's a fair amount of folks that when you sit down with them, they're like, I don't know if I trust you, doctor. And I don't know why I just went into a Southern accent, but I did. But they do this thing where they just don't believe you. So I think this speaks to our current healthcare system. We are killing belief because we are killing trust. And we're doing that by the way that we practice, by the way that we deliver this service to our clients. We don't consider it service and we don't consider it clients. We just like, I'm the doctor, you're the patient, and I'm going to tell you science and you're going to listen and you're going to believe me and you're going to do what I say and it's going to work. That's what we think. That is so dumb. Come on. It doesn't work that way. One of my favorite things about the way we work is time. It's just time. So we spend 30 to 60 minutes with our people and we're able to build trust in that time. We're able to listen, to validate, to do the things necessary to build that relationship so that when we do give them good advice, they believe it. And then it's synergistic with the power of the medicine and science and placebo and belief. And they both work together for their good. That's really awesome. So I think that we in healthcare need to take a strong look at that. Is it worth 30%, up to 30% less good outcomes by killing trust and belief in placebo to continue to practice the way that we're practicing? 5, 10, 3-minute visits, hurry up, wait in the waiting room, and no relationship, next, be treated like a number. We're killing the power of trust and belief. Trust is sacred, belief is sacred, and if it is to us to maintain moral fortitude in evidence-based advice and evidence-based practice, and I think it's clutch. It's just so clutch. Today we saw a gal from Canada. Brutal healthcare experience, brutal. Broken system. Their broken system makes ours look like a joyride. Like it's nuts. I was able to spend an hour with these folks talking to them. It was a mother and a child. The mother cried like 4 times just in the listening part alone. About 3 or 4 times I said to them, I believe you. And that was so powerful for them to just be validated. Both of them were like, oh, someone who believes us. It's really, really tough, I think, to work in a healthcare system where trust and belief are being destroyed. And it is to us to take it back and be more careful with it. Mm-hmm.
I think it's just even harder that a lot of people in that system don't actually believe that their patient's belief in the treatments affects their outcomes. They don't think it matters whether their patient believes them or doesn't believe them or trusts them or doesn't trust them. They just know there's evidence for this thing, therefore it will always be the same no matter what. But when the treatment itself might be the same, but the belief effect is a separate thing. And if they lose that, then that's part of their outcomes is decreasing that. And it's really not a good thing.
It's the art of healthcare. It's more than just left brain science. It's right brain art, care, trust, and love. Dare I say love? And it's beautiful and it's really powerful. And we as scientists are remiss if we don't recognize the importance of it in synergizing in clinical medicine. Like we have to do that. We have to do a better job of that. There are many, many wonderful docs who do that. There are many wonderful docs that do that very well. And so that's really cool. We talked a little bit about nocebo. Can you break down this concept to us, Eric?
Yeah. So nocebo is when your doctor or someone else says either it's not going to work or they list every single side effect possible, and then you're worried about the side effects, and then you get the side effects.
Yeah. I like that you threw me under the bus immediately. Your doctor tells you it's not going to work. I almost never tell people that thing is not going to work because of that effect, because I'm very sensitive to belief and the power of belief in helping people. So I'm like, awesome. Sounds like someone told you that that's going to work for you. If you believe that is true, you should do that thing. I will then look it up on examine.com and see if there's evidence behind it and say, hey, there is a reasonable amount of evidence behind that suggestion from your friend. or I'll let them know, hey, there's not a ton of evidence there, but I think if you want to try it, I don't see any harm in doing that. If it is harmful, I'll say, hey, harmful, not okay, don't do that thing. But I almost never do that. But let's talk about the side effect thing. You know, I see people all the time, like all the time. So speak to that.
Yeah. So if you tell someone, like, we've talked a lot about SSRIs, but if you tell them, hey, you're going to get these symptoms, chances are they're more likely to have them. So you're going to get headaches, or you're going to get dehydrated more quickly. Those things are going to happen when they might not have happened if you hadn't told them.
Yep. So don't hijack your belief and placebo. Don't hijack that. That's nocebo. And hijack it by, so people say, hey doc, what am I going to have for side effects on this medicine? I say, none. You're not going to have any side effects. In fact, you're going to have a positive effect. It's going to be this, this, and this. This is how it works, and this is why. And then they're like, okay, cool. But what are the common side effects? I'll say, okay, well, there might be headache, maybe nausea, you know, but most people that I prescribe this to don't have any of those symptoms. I don't expect you to have any of those. Again, I'm leaning into that power belief, right? And I'm trying to lean away from nocebo. Well, then they go to the pharmacist who hands them immediately this giant list of side effects, and then they read it, and then they go to Google and they Google it, and they're just like destroying the power of placebo, the power of belief, the synergistic power that holds, and creating doubt and fear in that space. And so be careful of that process. I would say to people, don't do that. Don't just try to hijack your belief system by saying, well, I don't believe this doctor. I'm going to go look up all the side effects and I'm going to have some of those. You're going to manifest those in your life. Like, that's so true. And it does happen, like manifesting, right? These words are awesome. But that's what we're talking about. We're talking about a belief that becomes reality because of your belief in that thing. It's super true. Super true. Derek, there was a study that you were talking about like a belief in like the placebo piece. Can you speak to that?
Yeah, so I was recently learning about all these different studies that have been done in the placebo field in preparation for this. And I think one of the foundational things to understand about the placebo effect, it's kind of put out to be as a creation of the mind, essentially. That like these differences that you're experiencing are just a creation of your mind. They're not like reality. But like the reality from what research has shown is that there actually are brain circuits in your prefrontal cortex that reflect your expectations and your beliefs. Which, obviously your brain reflects all of your thinking. That's not a surprise there. But what is interesting is they've mapped out circuitry that this has output onto parts of the brain that affect your body. And so effects on your hormones, effects on your heart rate, your blood pressure, your breathing, your immune system, all these different systems in your body that very much do affect your health, are affected by your beliefs and your expectations. And so they've done studies, for example, they had one where they had 3 different placebos. So they're all placebos. One's a red pill, one's a yellow pill, and one is a blue pill. And they gave them to 3 different groups, and they told them, like, first of all, this one's going to improve your sleep. And so there's 3 different colored pills, and all of them are placebos. The group that took the blue pill had more improvements in sleep than the others because their belief in their blue pill probably looked the most similar to melatonin in their head, They're like, oh, this looks like it's going to work. This looks like a sleep pill to me. Mm-hmm. They saw the biggest improvements.
Blue's a calming color. It's like, okay.
And then they did the same thing, but they told them, this is a pill to help. One of them was for like anxiety, depression type of symptoms. The one that was yellow did better than the other placebos for those other things. So these different associations we've made in the past with different things and different beliefs we have about even just, what color is this pill will manifest in, the symptoms. They've even found that the more invasive a placebo is, the more it has an effect. For example, a capsule has a bigger effect than a tablet.
Yeah.
An injection has more than a capsule. Yeah. And if you put like an actual limb in a machine or like use an actual machine, that has the biggest placebo effect because it reflects a belief system in our society that the more invasive a procedure, the more successful it's going to be. So that just reflects back on us and our own beliefs as a society.
Totally. The podcast is one of our favorite podcasts, actually. Huberman Labs is awesome. He just does wonderful scientific work in the science and understanding space. And so that podcast on placebo and nocebo is awesome. And so, yeah, we all listen to it, and it's just fabulous. So really appreciate that. I want to give props out to Andrew Huberman and all his work there. And there's a book in that podcast. Do you recall who wrote that?
I think it's called Placebo, and I don't recall who made it.
Yeah, me neither, but it's fantastic. And he quotes all those sites, all those studies, and it's just super fascinating. So what you're saying is there's neuroscience behind manifesting.
Yeah.
There's actual neuroscience.
Your brain has output onto your body to make your beliefs come true to a certain extent. Obviously, there's only certain outputs it has, certain systems it can modulate. So, you can't believe that something's going to get rid of your cancer tumor and it will just happen. But it's more in the realm of like modulating your autonomic nervous system, feeling more calm or more anxiety, having, different things like that the brain does have output directly onto the body.
I was fascinated by one of the studies they talked about in there where they injected them with a medicine that increased some hormones in their body. I think it was like norepinephrine and serotonin. And it was sumatriptan. Yeah. And it increased those substances in their body. And then a few weeks later, they injected them again with just saline, and the same effect actually happened in their bodies, which is super fascinating. Mm-hmm. That tells you there's like an actual physiologic, like hormonal change that can also be induced by our brains. Wow. That's like amazing stuff. I think it speaks to the power of positive thinking, right? The power of, okay, this is going to work. Thanks, doc. Mm-hmm. See you later, right? Take it, feel better, get better. I think it's powerful, and we can lean into that in our lives in a bunch of different ways, and just the power of, I don't know, manifesting goodness around us by just leaning into really healthy, positive thought processes, and maybe leaning away from processes that are fearful and doubtful. And, those, it's funny, we're talking about science, we're talking about being a little bit trepidatious about some things, but there is power in conclusion. Yeah. There's power in just believing something and going with it. And so I think in our space, I hope this podcast is helpful for folks as they're just navigating health and wellness and products and different things, to lean into positivity, lean into it, but then also maybe be conscientious about some of the conflicts of interest and some of those things that are maybe not as sciencey and as true or real as we would like them to be. Mm-hmm. Any other thoughts in closing?
I think it's just, we kind of propose two different opposing thought processes, and it's hard to find a harmony between the two of them, because the more you scrutinize everything and don't believe everything, you kind of negate that placebo effect that is positive. But at the same time, it might cause you to be overspending on products that, aren't really working the best for you. And you could be, finding something that does have some evidence behind you, as well as, leaning into that belief for it and getting both benefits rather than getting one or the other.
Yeah, it's easy to go down the wackadoo trail. And then it's easy to go down to super science nerd, like kind of a jerk trail, right? Yeah. And so there's some balance in those opposed thinkings, which is, in my thought process, it's like a right and left brain balance. It's a science, evidence, research driven foundation with the art, understanding, belief mixed into that. And I think as you guys move toward becoming doctors and on your journey, be sensitive to that process. And you're going to be super heavily indoctrinated into the science and into evidence-based, et cetera, et cetera. Wonderful, wonderful. Yes. Also maintain an empathy to belief and the power of that belief. Yeah. Eric, you had a comment.
Yeah. I think, with the combination of belief and then also these proven treatments, like it's kind of a win-win situation, because you're getting both. And like, I consider myself a very optimistic person. And so like, I really lean into the placebo effect, probably unconsciously. Mm-hmm. At the same time, I've also had really good experiences with the things I've been prescribed.
Yeah.
And, I've looked into things. So whenever I've had a doctor tell me, hey, you should go on this medication, I usually ask for a moment, hey, explain it to me. Explain how it works. And then sometimes I'm convinced right off the bat and I'm leaning into that placebo. And other times I need to research it, and that's totally fine as well.
Yeah.
And then I find, oh, hey, this actually does work.
Yeah.
And so then the placebo effect is back on and I get that synergy.
Super cool. Well, thanks, guys. This has been really fun. I hope it helps. I hope it helps everyone out there just learn more about science and about placebo and belief, and find that balance between the two as you navigate your healthcare journey. Like and subscribe, and Voyage Clinics podcast signing off. Thanks.